let's move to non-clear cell, which is sort of the, the poor stepbrother of clear cell, and we sort of lump it all together, which it's not. And I guess maybe just same question as I asked for clear cell. We'll go in reverse order. Hans, I'll let you go first. So a typical non-clear cell patient, and I know you may want to differentiate by histology, but this frontline metastatic papillary or whatever, how do you approach that patient?
Yeah, papillary is easier among the non-clear cells, I think. I think it's very clear that we do actually have activity of immunotherapy in papillary renal cell carcinomas, depending on what you look at, maybe like around 20% plus a little bit. And TKIs can work, and then there are these combinations now, obviously the doublets, Cabo-Nivo, Len-Pembro, shows very nice respectable response rates, 50%. And I think one of those would be actually my go-to frontline work. Now, may I be tempted in some select patients maybe to use single agent immunotherapy, maybe in some with really small disease burden, but otherwise the disease control is not good enough for me. So there I'm really tempted to combine it with IO.
So an IO-TKI. Do you use Ipi-Nivo in any non-clear cell patients?
The data has not been strong. There's some data sets. Actually, another data set coming out of that is being presented at SITC, for example, is actually uniquely strong with response rate like 40%. But I would say other data sets are more like in the high 20s. So it didn't seem to add as much as what we've seen with clear cell. So I was less tempted to do it. Maybe if it's like a young person who wants to go full in immunotherapy, but it's also not in the guidelines. It's not necessarily approved for it. It's a little bit of an uphill fight to get it approved. So I tend to stick with IO-TKI for now.
David, what's your approach?
I think it's similar. There's some trials out there in papillary that are interesting. I mean, the Sameta trial, could help us, as far as a randomized trial.
And tell us what that is, the Sameta trial.
So I believe it's durva versus sunitinib versus the combination of durva and the MET inhibitor.
Correct. Yeah, I think that's right. Yeah.
Savolitinib?
Savolitinib,
yes.
Also,
so
I always said salsolitinib, which would have been wrong. Yeah. So that's an interesting design, and that'll, looking at not quite component parts, but sort of, and give us a sense of whether to a MET inhibitor that seems active in papillary, can you add IO and enhance the benefit? I think one of the things that's exciting to me about the field in the last 5 years is our colleagues have shown that you can actually accrue these trials. Yeah. Back in my day, you couldn't enroll these trials, and now we've done a series of them, which I think helps in two ways. It gives us more clinical data to look at, and it also gives us more tissue to analyze. And there are data sets that we need to get out there and analyze. So one trial that I'm in theory responsible for, the Keynote 427, big group of non-clear cell patients with...
Biggest trial ever done, right?
Yeah, well, it's, I guess.
It's up there, yeah.
As far as single agent checkpoint. But the point of the story is the story is only partial. We have early clinical outcomes. We don't have late. We've had some translational data. We don't have all of it. It would be great to try to connect outcome with these modern techniques of interrogating the tumor, which people have done, but we need more of that. We need companies to support that analysis so we can actually connect, outcomes with
and in clinic, but in clinic you're giving IO-TKI to the majority of patients.
Yeah, I think so. For papillary, type 1.
For papillary.
Yeah, I think for chromophobe, we still believe in Tom Hudson's awesome Len-Pembro data.
9 patients.
It's not Len-Pembro, Len-Ev data.
Len-Everolimus.
Yeah, small, but I mean,
4 out of 9.
So they
most highly cited 9-patient cohort ever.
No doubt. I'm a desperate man.
No doubt.
So yeah, so we do that there, but I don't know.
Although, I mean, if you look at, I think it was Len-Pembro, the chromophobe subset, which was not, I don't remember the numbers, but it was pretty robust. Yeah, it was a decent number. It was more than 9, and it was pretty robust.
Yeah.
So
yeah. And there's a Keynote something trial that they did in multiple countries that showed like a close to 50% response rate in non-clear cell patients with Len-Pem. So I think you have things to build on, but we need much better connections between the tissue and the clinical outcomes than we have now.
Agreed. Tian, anything to add to that
approach? I agree with my colleagues. If we focus on chromophobe for a minute, from the early trials, right, ESPN and Aspen, that chromophobe population tended to actually favor everolimus and mTOR signaling. Lisa Hinsky has done some really careful biology around chromophobe renal cells, and there's some hint of ferroptosis driving some of the susceptibilities. And so I'd be really interested to see if there's ways where we can target those cysteine receptors and think about, how do we undermine the biology of each of the subtypes, because we know chromophobe is different than papillary and is different than translocation type, right? So we want to be able to figure out the best options for those subsets of patients.
So it sounds like we're all, and I agree, sort of IO-TKI based on single arm but reasonably impressive data. And I think leneverolimus is a good regimen, albeit toxic and not curative, right? And so I think immune-based regimens can be curative in non-clear cell. I'm not sure what those numbers are, but that's what I tend to do as well. But I think, and David, I think you said this, the best news is that we're actually enrolling these patients. We're realizing that it's not one biology. And then the next step, I think, is translational and new targets.